Hello, everyone. Welcome back to the Mission Control Virtual Conference, a full day dedicated to standing up to superbugs and surgical site infections. I'm Lisa McCown from Beyond Clean, and I just want to take a moment to thank you all for joining us today. For those of you anxiously awaiting your CE credits, after viewing all of today's sessions, you'll have access to the full conference survey and will be able to download your CE certificate. Joining us next is Robin Collins. Robin is the Vice President at Path03Gen Solutions, a Florida-based company and the creators of the Ozone shoe sanitizing station. As a seasoned healthcare professional, Robin has a vast knowledge in infection control, medical devices, and pharmaceuticals. Robin is a health education liaison program coordinator and is passionate about connecting healthcare professionals with continuing education. Have you ever wondered how microorganisms from hospital floors can transmit into the air and even spread to our hands? In a time where disinfection is at the forefront, how do we protect ourselves from this unknown microbial threat? Robin is here to shed light on the key disinfection principles of UV and ozone disinfection. She will also describe the disinfection methods available to control microorganisms transmission in healthcare environments. This presentation will have you busting out of the disinfection wipes. So without further ado, let's welcome Robin.
Thank you so much, Lisa. I greatly appreciate the introduction. And thank you to the entire Beyond Clean team. I also want to thank all of you participants for hanging in there for the last discussion presentation of the day. So as Lisa told you, I'll be talking with you today about the principles of UV and also ozone disinfection and the risks of floors and shoes for potentially disseminating pathogens to surfaces and also to the air. Lisa already did a great job at introducing me. As she mentioned, I am Vice President with Pathogen Solutions, and I have more than 30 years experience in industry with both large companies like Merck Pharmaceuticals and Guidant, and then small startups, including several in the infection prevention space, such as Vestigen, which has fluid repellent antimicrobial scrubs, IsoClean, which has a proprietary disinfection system, and also previously worked for companies EV3, which is now owned by Medtronic, and Spectranetics, now owned by Philips. So our topics to be discussed today include how ultraviolet disinfection can destroy the molecular structures of both DNA and RNA. We'll review the 4 bands of ultraviolet light, including the germicidal UV spectrum, also known as UVC. We will touch on how ozone, or O3, is used in disinfection and how that works. We'll then transition to a discussion on how microorganisms on floors and shoes can quickly, broadly, and persistently spread to your hands, as well as to high-touch areas, and then also be redistributed into the air. We'll discuss the relationship between microbial load and infection rates, and then we'll discuss current methods to control floor and surface and air transmission of pathogens. And of course, I'm happy to answer any questions you might have. So thank you for hanging in there on the home stretch. We believe that sterile processing in the operating room should be the cleanest area in the hospital, and I'm sure you do too. So why is clean important? And before I review this slide, I want to say that these are actually pre-COVID numbers. The CDC issued a statement in September of this year that said healthcare-associated infections drastically increased in 2020 over 2019, and most significantly was fourth quarter 2020, where there was a 47% increase in central line-associated bloodstream infections, a 45% increase in ventilator-associated infections, 34% increase in MRSA, and a 19% in catheter-associated UTIs. With that said, without question, the key reason in hospitals to focus so on cleanliness is healthcare-acquired infections. In the US, on average, we have about 1.7 million HAIs per year. The cost to the society and families is significant. Approximately 99,000 people pass away each year from preventable infections. The cost to the society and economy is staggering, between 35 and 45 billion. And the cost to hospitals, and this is conservative, just direct cost alone, is approximately $22,000 per just one healthcare-associated infection. And on average, patients stay in the hospital for approximately 19.2 days. So let's take a minute and talk a little bit about the origins of UV light for disinfection. Researchers initiated research on using UV light to kill microorganisms way back in 1845. And then Downs and Blunt in 1877 actually proved that ultraviolet light is effective in killing microorganisms. What they did is they exposed test tubes to sunlight, and they found that it prevented growth of microbes inside the test tubes. And through longer exposure times, the test tubes remained free of microbial growth. So how does UV disinfection work? Pathogens are present on all exposed surfaces to some degree or another, and they can live a long time and regenerate on surfaces. An example is COVID-19 can live, depending on the surface, for anywhere from 3 days to 17 days. E. coli can live on surfaces for 16 months, MRSA for up to 7 months, and VRE for up to 4 months. UV light is lethal to microbes. With the appropriate intensity and exposure time, UV light inactivates microbes and viruses by destroying the DNA and RNA. So the key takeaway for this slide is that UV light exposure damages the DNA and RNA of microorganisms and prevents them from replicating and regenerating. So UV radiation is classified by wavelengths and measured in nanometers. What's a nanometer? It's 1/1,000,000th of a meter. Wavelengths are described as the distance between peaks within a series of waves. And there is UVA rays that have the longest wavelength, followed by UVB, UVC, the germicidal range, and then UV, which have the shortest wavelengths. So the 4 bands of UV light within the spectrum of light are electromagnetic irradiation with wavelengths from 100 to 400 nanometers, shorter than that of visible light, but longer than X-rays. And you can see here the 4 different categories, with number 2, UVC, between 200 and 280 nanometers, as being the germicidal range. And what you can see in this display is with the UVC, you see a spectral curve of cell interaction, or of cell irradiation. And the optimum or peak germicidal wavelength is between 254 nanometers and 262 nanometers. So if you're looking at UV products, it's important to remember that the range is 200 to 280, but optimally, you'll want a technology that has 254 to 262. Let's now shift and talk a little bit about ozone. Ozone is 300 times more effective than chlorine bleach. It was initially studied primarily in Europe in 1840s. Von Siemens in Berlin was the first to manufacture an ozone generator. Then in 1893, the Netherlands worked on applying ozone to clean water and to purify it, but it was actually the installation of ozone in 1906 by French scientists that has made Nice, France, considered the place of birth of ozone for treating drinking water. So we talked about UV and UVC, which is light. Ozone is actually a gas. It's a gas formed by molecules of 3 oxygen atoms. There's one strong double bond and there's one weak single bond. And that weak single bond breaks off and is a powerful oxidizing agent. How it works is it actually puts holes into the cell wall and cracks the capsid or the outer cell wall, and is proven to be highly effective in killing bacteria, fungi, and molds, and also in inactivating viruses. And it's shown to be more effective against envelope viruses than naked viruses. So, in summary, the 3rd oxygen atom breaks off and attaches to the cell wall of the microorganism. It then opens up the cell and is able to, with the appropriate intensity and exposure time, affect the disinfection process. So the key takeaway is ozone single-bonded oxygen breaks off and bonds with the microorganisms, causing the cell wall to rupture and the proteins to be denatured. So I want to shift now and talk a little bit about the risks of floors and shoes in pathogen dissemination. I want to ask you a quick question to think about. When was the last time you sanitized the soles of your shoes? There's a study that was performed by the University of South Florida at a Tampa area hospital. It showed more than 70% of the people entering the hospital were carrying MRSA, C. difficile, and other harmful pathogens on their shoe soles. In a separate study, it was found that more than 400,000 bacterial units were found on a single pair of shoes. In a separate study, research found that 96% of shoes had fecal matter on them. Another study showed that the transfer of bacteria from the shoe to the floor is between 90 and 99% with every step. And we also know that pathogens regenerate or replicate quickly, and one parent pathogen cell can double every 20 minutes. So within 7 hours, that can create 1 million pathogens. Here's a study that appeared in Infection Control and Hospital Epidemiology in 2016. The investigators included Drs. Koganti and Donsky from Case Western Reserve and the Veterans Administration Hospital. What the investigators did, they took a non-pathogenic viral marker, they placed it on the floor of 10 patients' rooms. The staff was blinded, so they didn't know the study was going on, and they monitored the spread of that viral marker over a three-day period. It's a highly statistically significant study. What they found within the first 24 hours is the pathogens had spread from the floor to 100% of the patient's footwear, to 90% of the bed linens, and 40% of the time they found it on patients' hands. They also found it 50% of the time on the call button and 62% of the time on the visitors' chairs. What's equally alarming is they found it in adjacent rooms, at the nurses' stations, and on portable equipment. And this persisted for the duration of this study for the full 3 days. So the reason I share this with you is what's on floors and what's on shoes quickly, broadly, and persistently spreads to hands and high-touch areas. There are a number of other studies which also show that microbes on shoes and floors spread. You're probably aware that last year, the CDC issued a statement that COVID-19 may be spread on shoe soles. This was as the result of a study that came out of Wuhan, China, that showed 70% of the ICU workers and 100% of the pharmacy staff were carrying COVID-19 on shoes. In a separate study in Cambridge, England, what they found was that the survival of bacteria in dust, and that dust as well as fungal spores, etc., tend to fall to the floor. And then due to activity, walking, those pathogens can be aerosolized into the air. The next study is actually, again, the Koganti-Donsky study, showing that what's on floors and what's on shoes can quickly, broadly, and persistently spread. And then the last study here appeared at Infection Control Today. And what it showed, again, was that shoes and floors do play a role in hospital airborne infections. I want to now take us to a discussion on the relationship between a hospital's microbial load and infection rates. You can see a graphic here to the right, which shows the anticipated microbial load spread of pathogens over time if you don't have a way of stopping them from entering your hospital or entering sterile processing or the OR or other areas where you have immunocompromised patients, such as the ICU, the NICU, burn units, etc. Here's a study which showed that as microbial load increases, infection rates or colonizations increase. It also tells us here that any increase in interactions with pathogens that enter a patient's room can increase the likelihood of them becoming infected, including visitors coming into the room, wheelchairs, tools, shoes, and other elements. This study appeared in Open Forum Infectious Diseases, and it's entitled Microbial Load of Environmental Surfaces, the relationship between reduced environmental contamination and reduction in healthcare associated infections. This next slide addresses multiple different references which reinforce the same thing, that increased microbial load increases infections, and that by decreasing the microbial load, you can decrease the risk of infections. Currently, there are a number of ways we can address the risk of floors and shoes. One is shoe covers, another is shoe sanitizing stations, and lastly, floor cleaners and mopping. With shoe covers, we know they do not kill pathogens. They are a moderate risk of slips, trips, and falls, especially if they're too large. Additionally, putting shoe covers on and taking them off can result in contamination, in particular of the hands. With the pandemic, PPE has become more difficult to get and more expensive. Shoe covers are recommended as one-time use. If they get wet, they're likely to rip and tear. And it is recommended that they be disposed of as hazardous waste. Shoe sanitizing stations are proven to kill up to 99.999% of pathogens on shoe soles. There are low risk of slips, trips, and falls. Don't have to worry about the potential of contaminating hands. Companies have these readily available for purchase. What's nice is they don't require any additional staff, as do the UVC robots in towers. They can be plugged in and left on, and they're only activated when someone stands on them, and could be perceived as certainly a greener alternative. And then, of course, we have floor cleaners and mopping, which kill up to 99.9% of pathogens. They are a moderate to high risk of trips, slips, and falls, even when we put signage out. Also, sometimes they can make floors sticky. There's the potential for contamination when both mopping and wringing. Cleaning supplies are harder to get and more expensive now, and the chemicals do need to be disposed of after use. So here's a study which you can find on the NIH website about shoe covers. And the conclusion of this study is that shoe covers are not effective in lowering infection rates, lengths of stay, or mortality. So there are currently 2 shoe sanitizing stations on the market. One is the Ozone shoe sanitizing station from Pathogen Solutions, which uses the powerful combination of ozone and UVC, and the other uses UVC only. I want to quickly review with you the disinfection hierarchy of pathogens, which you can find on the CDC website. This was developed by Doctors Rutala and Weber from the University of North Carolina. What you can see on the top are the pathogens that are most resistant to sterilization, or those which are most difficult to kill. And without question, the most challenging ones are spore-forming bacteria, such as C. difficile and Bacillus subtilis. And then as you work your way down the hierarchy, the least resistant to sterilize being the enveloped viruses, such as the HIV and the flu. Here's a comparison chart at 8 seconds of the effectiveness of UVC at 254 nanometers. On the left side, it's UVC plus a trace amount of ozone, and on the right side, UVC only. You can see with the first pathogen, MRSA, the results are pretty similar, but the blue column in the middle shows you that that trace amount of ozone on MRSA makes that technology 1.4 times more effective. If you go down to the second pathogen, C. difficile, where we have spores, among the most difficult to kill, with UVC plus ozone, the log reduction is 3.25 with a 99.944% reduction. Assuming you start with 1 million pathogens, that means 562 are left behind. Or in other words, this technology is 263 times more effective than using UVC alone, which only has a 0.83 log reduction or an 85% reduction, meaning that out of 1 million pathogens, almost 150,000 would be left behind. And you can see this consistently with other pathogens, including VRE, E. coli, Pseudomonas, and at the bottom, human coronavirus. That trace amount of ozone makes the technology 24.5 times more effective than using just UVC alone. General information about the 2 technologies. With the UVC only technology, it does require assembly. Both technologies are able to track usage for compliance, and both are able to be plugged in and used 24/7 without any additional staff. The UV plus ozone technology offers a seamless traffic flow. You can walk from a dirty area, stand on the unit, and walk straight ahead into the clean area. With the other technology, you have to walk backwards or sideways and risk quickly again contaminating the shoes. The UVC plus ozone technology is water resistant, the other is not. It's effective on all footwear, and as I mentioned, is a step forward into clean. The other technology is not. Additionally, in terms of disinfection efficacy times, both technologies can be set at 6 and 8 seconds. Only the UVC plus ozone technology can be set at 10 seconds for up to a 99.999% kill rate. Additionally, only the UVC plus ozone technologies been proven to lower HAI rates by 53% when used as a layered approach with other infection prevention technologies. And of course, floor cleaners and mopping protocols. There are three primary protocols. The first is the one bucket protocol, where the disinfection solution quickly becomes loaded with contaminants when someone has to wring out and rinse out the mop. Two bucket protocol is certainly better than one bucket, but optimally, the three bucket protocol is the industry standard in practice. The challenges with it is it takes longer, of course, it requires more cleaning solutions, and it's more expensive. But it is an important component within a layered approach for infection prevention. So I'd like to just quickly summarize what we talked about today. Ultraviolet disinfection can destroy the molecular structure of both DNA and RNA, and in particular, UVC offers germicidal effectiveness. Ozone, or O3, is also proven to be a highly effective disinfectant. There are multiple studies which show that what is on floors and what is on shoes quickly, broadly, and persistently spreads to hands and high-touch areas and can also be aerosolized and breathed in. There are multiple studies which show an increase in microbial load results in an increase in infection, or in other words, by decreasing microbial loads, you should be able to decrease infections. And then lastly, there are multiple alternatives for preventing the spread of pathogens from floors and shoes to the surfaces and air. With that, I invite you to ask the questions you have, and I'm happy to do my best to answer them for you.
Wonderful, Robin. We actually do have some questions in the queue for discussion, and I wanted to take a second to invite anyone else listening to go ahead and add their questions as well. First one is, what are your thoughts on opening doors and fanning towels and wrappers, as well as using air guns in a clean area such as sterile processing? Do you think that those kinds of activities would increase the chances of recontamination for both medical devices and technician exposure?
That's a great question, and I haven't seen any scientific studies, so I'll just anecdotally say from my perspective, I do think that potentially that could be an issue, because what's on floors can be re-aerosolized if there's a lot of activity in a given area.
Yeah, and if you think about the textiles, how contaminants and particles can adhere to scrubs and, as you mentioned, kind of like aerosolize and land on different surfaces, especially dust and so forth. It's easy to see how recontamination of medical devices in trays and sterile processing with air guns and so forth would definitely be a concern. Another question is, would you recommend one sanitizer on decontam and one on coming onto the clean side? What are your thoughts on that?
Yes, I think, yes, Kim, I think that's a great strategy, is to have two in those different areas. Also, sometimes in SPD, they'll put them in the employee break rooms and or entryways into different areas of sterile processing.
Is this the kind of technology that you could put a badge and other handheld devices such as a pen or a cell phone into to disinfect?
Unfortunately not. It's actually both the shoe sanitizers available are really designed for disinfecting the soles of shoes. I mean, theoretically, absolutely. I mean, someone could put things on here and stand on it to activate it and clean the sides one at a time. But ideally, there are other technologies, UVC boxes, that are sold where you could just put items such as those in instead.
So how do you break the habit of staff wearing the same shoe covers for their entire shift?
That's a great question. It's a lot of education. I mean, and it's having, people there to point out that they need to be changing them. Yeah, I think that's a big challenge for everybody. I think all of us working in hospitals have seen people wear shoe covers out of a given area, down the hall, sometimes even to the cafeteria, et cetera. So it's a challenge, but it's an important challenge worth staying on top of. We are working with some hospitals who have chosen to move away from shoe covers and just use the shoe sanitizing stations.
Then, in your experience, how would you recommend that perioperative teams implement solutions for eliminating the risk of cross-contamination related to shoe traffic between disciplines? So perhaps using the technology that you're speaking of, how can teams start implementing those kind of practices when they haven't had that technology before?
That's a great question. I think a lot of it gets down to in-services and placements of units. Just placing them strategically in areas which could bring together multiple disciplines would be helpful. And then education, and then as well signage, providing an understanding as to why in only 8 seconds it's worth taking the time to stand there and sanitize shoes.
Another question just popped in. Have you seen healthcare facilities share the cost with the housekeeping department, such as environmental services, and then effective in terminal sterilization for the OR? So I think what they're asking is, considering the different disciplines that are coming in to the perioperative setting, it's not just, the operating nurses and scrub techs and surgeons, but it's all of these different groups. So what are your thoughts on that?
You know what? No two hospitals are the same. We have had an environmental services company buy units for hospitals and in essence give them as one of their value adds. And then the hospital administration decides where to put those units. In another situation, we have a hospital that has units in the operating room, sterile processing, and the pharmacy. In that situation, each department utilized their own budget in order to acquire the technologies. But I think share costing is a great idea. And the reality is OR and sterile processing work so closely together that if they're able to share costs, I think it's a great idea.
And then, so this question just popped in. What would be the best solution when coming out of the dirty room, so decontam, to keep floors less contaminated?
Simply shoe sanitizing stations. I mean, you can use them going in and you can use them going out. The cutouts face one direction on the UV zone one, but you can stand on the cutout in either direction. It works just as effectively.
Yeah, I know that a lot of times decontam in sterile processing and even the clean area of sterile processing is usually only, the floors are usually only wiped down once a day, typically. And whereas in the OR, they have terminal cleaning after every single procedure.
Yeah.
So, and I've been in quite a few facilities where the only kind of floor cleaning that takes place is when EVS brings in one of those floor buffers. And so there's really not any disinfection happening with the floor in that instance. It's just a device that's going through and, you know, doing a quick mop with a machine. And then they're taking that device, they're taking that floor buffer into another area. And then, you know, there's a question of whether or not that device is being disinfected, you know, between going from the decontamination area to another area in the hospital. So is there any thoughts on protocols that can be improved for improving the environment of care cleaning practices for disinfecting these areas?
You know, that's a great question, and certainly without question. The CDC cites that within hours of disinfecting floors, they're back to pre-treatment levels. And so why is that? It's because pathogens regenerate, and they can regenerate quickly. It's because people cough and sneeze, and even with a mask on, it can aerosolize out the side or fall to the floor. And then the reality is because people walk on the floors again. So, I mean, ideally, I think there does definitely need to be a way to ensure that floors are disinfected in those areas. And then also anything you can do to prevent pathogens from being carried back in and carried in and out on shoe soles is of critical importance, which has been greatly overlooked until the last couple years.
So another question, we are taught that we can't effectively disinfect or sterilize without cleaning. So how does this technology work, considering that you're stepping on a sanitation device with contaminated shoes? So can you speak to that?
Sure. The way that it works is you step on the technology, that activates it. And then the UVC and with the one technology, Ozone, are turned on, if you will. And they work to rupture the cell wall, to denature the DNA and RNA, and ultimately kill the pathogens and decrease the likelihood that they're going to be regenerating because they've been killed and denatured.
We've got time for a couple more questions. Is there a need to monitor employee for exposure to ozone if a sanitizer is used?
That's a great question. The UV zone went through 18 months of rigorous UL certification. It also was evaluated by a company called Ozone Solutions. It's only a trace amount of ozone which is emitted from the unit, and it is within OSHA safety standards. So the long answer to the question, or rather the short answer, is no, you don't have to worry about that. That trace amount of ozone is recirculated back into the unit using fans, and there's a carbon filter in the unit as well. So based on studies from UL and also Ozone Solutions, it shouldn't be a concern. But great question.
Does UV ozone station platform, should that be wiped or cleaned every time you step on it since your shoes are contaminated?
No. The reality is once you stand on it, it cleans not only your shoes, but the glass that you're standing on. We do, however, recommend that once a day, someone unplug the unit, use some kind of window cleaner or other cleaner used in the area, and just wipe down the unit. But no, there's no need to clean it in between each use. In essence, it's self-cleaning with regards to microbes.
What is the weight limit for the sanitizer?
That's a great question. That comes up a lot. Both technologies' weight limit is between 400 and 500 pounds. Also, with that said, for UL testing, it needs to be tested for up to 4 times the weight limit. So both units have been tested up to, I think it's 1,600 pounds.
Okay. I think we have time for one more question. I'm just reading this one here. Looks like most of the other our comments just really talking about how much this presentation was very informative and how much they've gotten out of it. Here's another one. How many users? Is there a monitoring device to prove efficacy? Oh, how many uses?
There is a monitoring device regarding number of uses on both technologies. So it can monitor the number of hours per day the unit is on and the number of engagements or activations uses during that time frame. Also, with the UV zone, it can take an algorithm and provide you with an estimate of the number of pathogens that are killed per use and or per day within a facility or area where it's being used.
Okay, well, that's all that we have time for today. Thank you, Robin, so much for a great discussion and key disinfection takeaways. If any of you had additional questions that you'd like to ask Robin, feel free to connect with her via email or LinkedIn, and she'll be glad to follow up with you. And at this point, I'm going to turn it over to Melanie. Okay, I'm going to go ahead from here. As our day comes to a close, I would once again like to thank today's premier event sponsor, 3M. Without their support, this exciting day of virtual learning would not have been possible. And a special thank you to our industry experts for joining us for this virtual event. I'd also like to recognize all of the professionals who reprocess surgical instruments across the globe. For all of you who chose to spend the day educating yourself, we'd like to thank you for your dedication to professional development and best practice. And just as a reminder, you will find the additional bonus CE content in the downloadable resources tab. So make sure you check these out for the additional CE opportunities. And as this session's close, you'll be directed to the conference survey page. From there, you can download your CE certificate for today's 6 live sessions, and all of today's sessions are available on demand, so you can rewatch, share, and continue to access the downloadable resources and bonus CE content provided to you. Stay safe out there, sterile processing, and always keep fighting dirty. We'll see you next time.
Thanks again.